Hi everyone, my name is James Turner and I am from the Princess Alexandra Hospital. I will be presenting my case study titled Avoiding a Total Eclipse of the Heart, Unlocking the True Potential of PET MRI Diagnosing Cardiac Sarcoidosis. The aim of my presentation is to demonstrate the utility of PET MRI in diagnosing early stage cardiac sarcoid and its ultimate benefits in patient management. I will demonstrate my aim by exploring the clinical pathway of a single case study with suspected cardiac sarcoid utilizing PET MRI. Sarcoidosis is a systemic disease which is characterized by the growth of tiny collections of inflammatory cells known as granulomas. These granulomas can lead to fibrosis and scarring within the tissues, causing irreversible damage. The condition most commonly affects the lungs, the lymph nodes and eyes, as well as the heart in 5% of cases. Whilst cardiac sarcoid only manifests itself clinically in 5% of patients with sarcoid, it is responsible for sudden cardiac death in up to 25% of cases. The disease most commonly affects the myocardium, but can also involve the endocardium and pericardium, manifesting in one of three ways, being conduction abnormalities, ventricular arrhythmias, or heart failure. In this particular case, we followed the journey of a 45-year-old female who initially presented in January 2018 with a suspected detached retina. This was investigated and diagnosed as uveitis, which can be caused by sarcoid in 10% of patients. She had no acute respiratory or cardiac symptoms. In May and July 2018, the patient had a routine chest X-ray and a high-res CT, which was suspicious for pulmonary sarcoid. The patient then underwent a bronchoscopy and an endobronchial ultrasound with an FNA performed, which was negative for sarcoid. Clinical investigations continued with a right bundle branch block noted on an ECG and a normal echocardiogram. At this point, we would normally perform a PET MRI. However, the patient wished to avoid radiation, so a cardiac MRI was performed. The MRI demonstrated no evidence of myocardial infiltration or scarring. Yearly chest X-rays were performed to monitor the stability of the patient's pulmonary disease. Finally, in June 2021, the patient made her way to nuclear medicine and molecular imaging following another abnormal ECG. From here, the patient's diagnostic and treatment journey accelerated rapidly thanks to the results of these scans. Following a normal gated resting MPS study, the patient immediately commenced preparation for the PET-CT and PET-MRI. F18-FDG uptake within active sarcoidosis is due to the inflammatory infiltrates associated with the disease having much higher glycolytic activity. Patient preparation involved commencing a ketogenic diet 48 hours prior to the examination and fasting for 18 hours to reduce physiological uptake of FDG within the myocardium. On arrival, her BSO was recorded and her blood ketones measured at 0.7. The patient was injected with approximately 300 megabecquerels of FDG. The imaging protocol for initial diagnosis of cardiac sarcoid involved the patient undergoing a PET-CT and a PET-MRI in a single imaging session. The PET-CT is performed first with the imaging parameters shown in the green table on the left of screen to assess the body for systemic sarcoidosis. Directly following this, the patient commenced their PET-MRI, which takes 90 minutes to complete. It involves extensive cardiac-gated MRI imaging using the same protocol performed on a standalone MRI scanner. The two primary components are the functional component and the viability component, during which PET is simultaneously performed for 20 minutes. The viability MRI sequences utilize gadolinium contrast to assess the heart for late gadolinium enhancement, which is critical in the assessment of cardiac sarcoidosis and differential diagnosis. The PET-CT images demonstrated moderately intense FDG-avid lymph nodes in the submandibular and cervical regions, as well as in the bilateral axillary, mediastinal, and hilar regions. There were also avid non-enlarged lymph nodes below the diaphragm within the abdomen and pelvis, all consistent with the scan appearance of systemic sarcoidosis. The cardiac PET-MRI showed focal mild increased FDG uptake localized to the anterior lateral papillary muscle in the left ventricle with MRI enhancement. There was also low-grade uptake demonstrated along the inferior papillary muscle with no corresponding cardiac MRI abnormality. Both localized areas are highly indicative of cardiac sarcoidosis. The MRI images on this slide show just some of the functional imaging we're able to obtain utilizing PET-MRI. Critical assessment is undertaken to rule out other cardiac-related pathologies such as ischemia and myocarditis. These images also allow assessment of ejection fraction, which was normal at 63% with no regional wall motion defects. There was no evidence of previous inactive cardiac sarcoidosis, ensuring no irreversible damage had occurred. For this patient, the results of the PET-MRI study confirming cardiac sarcoidosis with no other underlying cardiac pathology resulted in a rapid change in treatment pathway. The previous watch and wait approach was no longer acceptable. Within 48 hours of the PET-MRI study being performed, the patient had an implantable defibrillator inserted to avoid sudden cardiac death. Performing both PET and MRI within a single imaging modality significantly improved reported confidence. On review of the initial cardiac MRI performed in 2019, the consultant believes had a PET-MRI been performed, there may have been disease present that was not called. Following the ICD being inserted, the patient commenced on a number of medications to further manage the disease long term. These images show how effective the treatment regime guided by the PET-MRI results has been. In September 2021, the patient returned for a PET-CT which showed complete resolution of the previously demonstrated cardiac uptake. She is experiencing no cardiac or pulmonary symptoms and her uveitis has improved. Early intervention is critical in the management of cardiac sarcoidosis, where timely diagnosis and treatment decisions have the potential to greatly benefit patient outcomes. Despite the negative biopsy, PET-MRI led to accurate treatment decisions being made that will ultimately benefit the patient for the remainder of her life. Whilst this is an isolated case, to date this technique is being used to alter management in over 55 patients. Major benefits of PET-MRI include the ability to assess active versus inactive disease, whilst utilizing the current gold standard imaging modalities for the accurate assessment of disease in a single scan. It overcomes many of the issues associated with cardiac MRI, such as movement artifacts, and significantly increases reported confidence. Overall, in this case, PET-MRI highly benefited the patient by assisting in avoiding sudden cardiac death and a total eclipse of the heart.
Nothing I can say, total eclipse of the heart.